I'm Earl Silverman, editor-in-chief of the Journal of Rheumatology. And for the month of April 2021, the article I have picked for my interview is entitled Evaluating Quality of Care for Rheumatoid Arthritis for the Population of Alberta Using System-Level Performance Measures. It is by Barber and colleagues from the University of Calgary, Alberta, Canada, University of British Columbia, Canada, University of Saskatchewan, Canada, St. Mary's Hospital, Newfoundland, Canada, and the Weill Cornell Medical Center, New York, USA. The paper is now available on the journal's website as an open access for viewing. I'm pleased to be speaking to Dr. Claire Barber, who is the first author of the paper. Claire, I want to thank you for taking the time to speak to me and to our listeners about your very interesting, important article regarding how health care for RA patients in Alberta met national system-level performance measures.
Thanks so much. It's a real pleasure to be here. It's such an honor to be selected this month. Thanks.
All right, so if we can start, could you briefly tell us why you felt the need to investigate quality of care of rheumatoid arthritis in Alberta?
Thanks so much for this question. So this goes back to 2016, and in collaboration with the Arthritis Alliance of Canada, we published this first set of performance measures for inflammatory arthritis care in Canada. And the measures capture important elements of care, including early access, early treatment, as well as ongoing access to specialist care and treatment for patients with inflammatory arthritis. And the present study is part of a larger body of work that was funded by a CIORA grant from the Canadian Rheumatology Association, where we collaborated with team members across Canada. That's why there's so many different universities involved when you listed that in the start. Really to test and report on these measures in 5 different provinces and in different types of data sets. And in this particular study, we review the performance measures in administrative data in Alberta, and this really serves as an important baseline as we investigate different strategies to improve care for our patients in our province.
So I guess you really have, are there any other of the performance measures that you want to let the listeners know about that you used in your study?
Yeah, so we talk about 4 of the performance measures from the original set. And so the first performance measure captures the percentage of patients who have a new diagnosis of RA. Now, this might be made in primary care or by some other physician who are seen within a year of that diagnosis by a rheumatologist. And so I really want to highlight that this is not intended to be a wait time measure, but it is more a measure of access to care at a system level, because unfortunately, there are many people who might not have access readily to a rheumatologist. And this might be especially true in Alberta. Most of our rheumatologists, especially during the time of the study, were practicing in the 2 large urban centers in our province. The second performance measure we evaluated was looking at the proportion of individuals who were dispensed a disease-modifying therapy at least once annually, including conventional DMARDs, things like methotrexate, biologics, and other advanced therapies. And I'll just highlight that this particular measure is endorsed by the American College of Rheumatology, and we adapted it in our framework so that we can have comparable results to what they're measuring there. The third performance measure evaluated the number of RA patients who were treated within 14 days. And this original benchmark had been established by the CRA for the Wait Time Alliance. The fourth performance measure examines the percentage of patients that are seen in annual follow-up by a rheumatologist. So those were the 4 performance measures we looked at.
Okay, it will be, this is an aside, it might be interesting to see how the annual visits by rheumatologists may change during COVID-19 with telehealth. That would be a very interesting to look at in the future.
Yeah.
So anyway, as I've said in other podcasts, that might be the one good thing that's come out of COVID-19 is telehealth and access to care.
Absolutely. Yeah.
So moving back to your paper is what we're here to talk about. Could you please summarize the findings of your paper?
Sure. As mentioned above, we used administrative data. So this is data from physician billings and hospitalizations, really to define our population of patients with RA in Alberta. And we used a validated case definition from the Public Health Agency of Canada. And so the study included data that was between the fiscal years of 2012-13 to 2015-16. And we identified over 31,000 prevalent cases of RA. And in the 2012-13 fiscal year, there were 2,730 incident cases. And so when we looked at each performance measure over each fiscal year, over time, there was an improvement in the proportion of individuals that were seen within 1 year by rheumatologists, from about 55 to 63% over time. But there were consistently low rates of DMARD use, and this didn't seem to improve over time. It was between sort of 42 to 43%. When we looked at incident cases only, and we looked at the median time between diagnosis and the start of a DMARD, this was about 28 days, so not really meeting necessarily that 14-day benchmark, with 41% meeting the 14-day benchmark by the last year of measurement, the 2015-2016 year. And then when we looked at the number of individuals who were under the care of a rheumatologist, so they'd seen them rheumatologist at least twice, and then we looked every year thereafter, approximately 73 to 80% remained under the care of a rheumatologist in each year examined. And so those were the main findings of our study.
Thank you. And you think, as you pointed out, you had investigators from all over Canada. So do you think findings can be not only generalized to other parts of Canada, but maybe other types of care system, privately and publicly funded?
That's a great question. So we've done evaluations of the measures using admin data also in British Columbia, and we're currently completing an analysis in Ontario as part of a CIHR-funded study, along with Jessica Whitfield, using the ORAD, which stands for the Ontario Rheumatoid Arthritis Dataset Cohort. And really, they're very similar kind of findings. The one thing I would highlight, and that we've looked at in other studies but not presented in the present Alberta study, is that when you look at the measures, especially the percentage of patients treated with a DMARD increases for those patients with ongoing rheumatology care. So it's closer to 84%. So really having early access and ongoing care to a rheumatologist is really key here. And as for comparison to other health systems, we're really lucky in Canada to have a publicly funded healthcare system to be able to investigate this at a population level. Many of the other investigations I've seen of rheumatology care and care quality mainly focus on those patients under rheumatologist care, and they really miss the bigger picture. For example, in the United States, they have the RISE database, where they look at actually the percentage of patients under, getting DMARD treatment on a regular basis, the same measure that we talked about. They have very high rates of measure performance on that particular measure, but they're really not looking at patients who might not have access to rheumatologist care. And so internationally, I think that many regions struggle with rheumatologist workforce issues, as we've seen in a number of studies published in Canada, the United States, and elsewhere. And I think if you don't ever look at the population level, which many places haven't, then you're not going to really understand the full picture for many of these system level measures.
Good. I wonder if some of the people who don't see rheumatologists have more, this is just a pure conjecture, have more mild disease. I know it's impossible with administrative data to look that finely at it, but you have to wonder that not every patient needs a DMARD, although the vast majority do.
Yeah, no, it's certainly one of the hypotheses, but and so that sort of brings us maybe into thinking about what are the consequences from a health system and also from a patient outcomes perspective of meeting or not meeting the measures. And so that's part of this ongoing CIHR work that we're doing in Ontario with Jess Whitfield, in BC with Dianne Lacaille, and in Alberta with myself and Cheryl Barnabe and others. And we're really going to be examining the impacts of this measure performance to understand better sort of the determinants of the measures, what kind of characteristics of patients are meeting or not meeting the measures, and then what are the impacts on health system outcomes, so healthcare utilization and costs, and then also on patient outcomes. And I think that this work is kind of really important in better understanding how these measures may be useful to health systems as we look forward to sharing this work in the upcoming year or so.
That's fantastic, and look forward to the new work, as I'm much older than you, it's just wonderful to see people looking at quality of care. I mean, I think we were looking at outcomes, and I think we were focused too much. And I think quality care is super important, and it's wonderful that there's all these bright investigators doing it. So is there anything else you'd like to add before we finish off?
No, it's just such a pleasure to be here and to see your face. It's been a long time, probably a year at the last CRA at this time of year. Hope to see everybody in person again sometime soon.
Yeah, we all hope so. Not this CRA, not this ACR. Yeah. Touch wood, 2022. Yeah. Mm-hmm. So, Claire, I want to thank you for speaking to me and all our listeners. And to all viewers, please read the full article entitled Evaluating Quality of Care for Rheumatoid Arthritis for the Population of Alberta Using System-Level Performance Measures by Barber and colleagues at jroom.org. We'd love to hear your comments on Twitter at jroom or by email manuscripts@jroom.com. And thank you for joining us, and hope to hear you next month when I will speak to the senior first author of one of my May picks. Bye for now and stay healthy. Thank you.